Hello, Peter.
Hi.
I'm Colin. I work with Healthcare for All Oregon.
Yeah,
Uh,
nice to talk with you.
Nice to talk to you too. We've seen each other virtually
Mhm.
for a long time, and now we're making this thing for the virtual world, but we haven't met in person. So it's great to sit down and have a conversation with you.
Yeah, likewise.
Yeah, I appreciate it. Can you tell me your name and sort of your a little bit about your background because you've landed on this committee,
Mm.
which has the potential to really change the course of healthcare in Oregon.
Yeah, I've been involved in healthcare for a long time. I have a PhD in clinical psychology. I've done research at Yale School of Medicine. I've done clinical work in a lot of different areas. Now I'm in a private practice. I work for myself, so I'm just a therapist doing therapy. The last time I had a job with an employer, I worked for the National Suicide Prevention Lifeline. So I learned from 2.5 years there, I learned a lot about just what's available and what isn't available all throughout the state of Oregon. Not just my little bubble in affluent Portland, but just everywhere. How where there's need and where there's options and where there aren't options. So now I'm a therapist, and I've done some work before with the Oregon Psilocybin Advisory Board. That was my first foray into doing stuff for the state of Oregon in like an official capacity. I was on one of their rules advisory committees about data collection and retention, which back in my Yale days, I did a lot of stuff with like research and data standards and things like that. So it was in my wheelhouse. And now I'm on the Plan, Design, and Expenditures Committee, which also a lot of data and numbers and graphs and things like that. A lot of things to consider all throughout the state of Oregon. So it really is fitting in with like pretty much everything that I've done with my life up till now.
Yeah, the path that got you to where you are today is long and twisty, and yet you've probably had this experience, or maybe applying to be part of the Plan, Design, and Expenditure Committee, where you're just like, oh, I'm exactly qualified for this role on this advisory committee. And you were chosen, so
Yeah.
that's really good. Can you outline the goals of the Plan, Design, and Expenditure Committee of the Universal Health Plan Governance Board?
Yeah, well, part of it is right there in the name. So we're looking to design the plan. Part of it is the expenditures, but there's also a financial committee. So we're kind of working in tandem with them. But we talked about who is eligible. That's a big one. Who counts as an Oregonian? There are a lot of competing definitions of that term just in the state law already. We don't need to make a new definition because there's already like 7 definitions out there. So let's just pick one. But they all have different implications. We were working on what kind of services should be offered. That was the first question, and we decided that for mental health, which is my field, OHP is the best model. Although, as I learned from my Lifeline days, the way that OHP is structured, like different CCOs throughout the state have different resources and different things that they offer their clients. So to say like we want our system to be like OHP, that's not specific enough because there's like 12 different kinds of OHP. So we decided to take just like the best of each, and just that's our standard for mental health.
When you say there's 12 different kinds of OHP, are you referring to the variety of CCOs that people around the state could be?
Yeah, okay, exactly.
And that is, to my knowledge, same but different to like the different insurance providers who have partnered with OHP, right? Because you can have Oregon Health Plan that's administered by Providence, for example, or administered by, I think, Kaiser. Is that also, are there discrepancies between those sort of managed plans, or am I misunderstanding something?
Yeah, I think so. Yeah, we looked at kind of the whole pot of something like Care Oregon, which is like its own nonprofit, not connected to any insurance company. But then there's like Samaritan and Pacific Source. So I like just as a regular therapist, I'm credentialed with Commercial Samaritan and the OHP that Samaritan handles. I'm credentialed with Commercial Pacific Source, but not the OHP that Pacific Source handles. I don't know why, but that's just a decision that was made somewhere. So it's a very fragmented system. So maybe it's one company that's like handling several versions of healthcare, and every system, and it's like there's fragmentation within that. And then there's, here's OHP, and there's a lot of fragmentation within that. So we want to just have one system, and we want the best of all of those. This CCO X does better with I don't know, home visits, home behavioral health. That's a thing.
Okay.
And then CCO Y doesn't really do a good job with that, but they do a way better job with outpatient addiction treatment. So in our combined system that we're making up, we want the best from X and the best from Y, so that everyone in Oregon gets the highest standards.
That's great. Ooh, that sounds like a lot to sort of tease apart and decide what you all consider to be the best. And so are there on your committee, are there about 12 members? I think most of the committees have between 10 and 12.
We have the most. We are the biggest committee of all of them. Good. I would say it's maybe more like 18.
Have there been any considerations or any decisions that there's been a disagreement on? Because I think that's the point of having a group of people with your expertise. Have there been any sort of conflicts perhaps that you've had to work through, or disagreements about what is the best way to bring care to most people?
A little bit, not nothing as heated as like city council or something like that, but we all want more money for primary care. We all want more money for preventative care, the social determinants of health. If we can get people healthy before they get sick, then that saves everyone time and money, and then they never need the hospital and the insulin and all this stuff later. So getting people when they're young, when they're healthy, having regular services. So preventative care, we love it. But we also need to help people that are already in the system, people with chronic health issues, people who are houseless. Preventative care isn't going to do anything for someone who's already houseless with mental health issues and addiction issues. But so everyone on the committee agrees we need all of these things, but what's the order of operations if we have to prioritize some of this? We don't have an infinite supply of money. So do we place prevention on is that first on our to-do list, or is that third? How do you what's the difference between, I really think I've been saying strongly that we need more at-home care and mobile care. I don't know the official term for it, but you can just get a bunch of nurses and staff on a big Winnebago, and they just kind of drive around and offer substance abuse screening. They'll do STI and HIV tests, give vaccines, really basic community care stuff. We need more of that. We need to reach people where they're at. Not everyone can or wants to go to a hospital or a primary care clinic. Maybe you want to go, but it's 5 months to see a PCP because we have too many specialists and not enough PCPs. So we need to get the providers to the patients.
Yeah,
that's a high priority for me, and that's everyone would agree. No one on the committee is no, don't do that. That's a bad idea. Of course not. But what's the priority? Should that be the top funding priority? Should that be number 4 on the list? So we have disagreements about the relative ranking of how to prioritize these things.
Hi again, Peter.
Yeah, hi.
We're now outside. So regarding the Plan, Design, and Expenditure Committee, what is maybe the most recent thing that you consider that you've accomplished as a committee?
Yeah, the last thing we accomplished was the definition of what is an Oregonian. And I don't remember which definition we picked, but that has gone to the main board, and they're going as a straw proposal. And so then it's up to the main board to say yeah, we think you're generally on the right track, or no, this is why are you even doing this? No, stop. And then they kind of give us some guidance, and then we come back to finalize it. So that's the last thing we did, and now we're in several separate committees to figure out how to pay people. And so I'm on the behavioral health subcommittee to figure out. So you get a big pile of money, and you give it to a CCO or some version, whatever we end up evolving the system into that's going to be kind of like a CCO, probably a different acronym, but we give them a big pile of money. And then it's up to them to figure out like how much of it goes to the hospital and how much to the this and how much to the that. And there are different ways to pay people. Like right now, so what I'm most familiar with as a therapist, fee for service. I see you for an hour, I bill Care Oregon for an hour, and they give me a check. Easy.
Yeah.
A lot of stuff's fee for service, but that's not always the best. You know, that's kind of paying people to be. It's really, for me as a therapist, it's in my best financial interest for you to keep coming back, even if you don't need to be. You know, or if I was some sort of medical provider to like do tests, even if you don't need those tests, because I get paid for the services.
Right.
So fee for service is not always the way to go. Sometimes you want a capitated basis, or maybe you could just like give someone a salary. Like I just get a monthly salary. It doesn't matter if I see 20 clients or 100 clients, I get paid the same. And then I just, then it's in my financial best interest to get people well so they don't have to keep coming back to me and I can have more free time. There's different pros and cons to all of this stuff.